She came here to Las Vegas and I did a full upper extremity evaluation. She certainly showed signs of bilateral neurogenic thoracic outlet syndrome, but she also showed pretty convincing evidence of additional nerve compression further down in the arms, sort of elbow level and down to the wrist. That involves removing the entirety of the anterior and middle scalene muscles and then addressing any other tight tissue bands, or sometimes you can have anomalous slips of muscle. There's a structure called a scalenus minimus that is present in some people that can compress the lower nerve roots of the plexus. The most common form of this surgery is where they remove the first rib and just sort of release or take out some of the scalene muscles. That's really kind of an archaic, unnecessary operation with a much higher degree of risk and morbidity post-op. The big name guys that do this surgery remove the rib. A lot of them, they see Major League Baseball players, and a lot of those players just never get back to form. The best operation for neurogenic thoracic outlet syndrome is to meticulously remove the entirety of the anterior middle scalene muscles. And so that's a much more technically difficult and tedious operation, because you're operating right in the middle of like a game of pickup sticks. If anybody remembers that. You have all these nerves and structures around you. You have to be inside there to remove the muscle, which is sort of inside all of those structures. You can't afford bleeding. That makes everything look red, and it's harder to see what the next thing is that you need to do. So it's a tedious operation. It's anywhere from 3 to 4 hours. You can release them and even remove distal portions of the muscle, but the innervation and the blood supply come into the muscle very proximally. Unless you're getting right up close to the spine and actually taking those muscles off the transverse processes of the cervical vertebrae, then you're leaving a lot of muscle and it just scars down to the nerves again, and those muscles can still contract and move. Most people who are doing brachial plexus surgery are vascular surgeons or maybe cardiothoracic surgeons. They're sort of one-trick ponies. They do this neurogenic thoracic outlet syndrome surgery, but they don't even bother to assess whether there's additional nerve problems downstream. And so if a patient doesn't have a great outcome or they still have symptoms, they just sort of think, well, there's nothing else you can do, instead of understanding where all the problems lay. From my standpoint, the next step for me would be to do the left brachial plexus.